Thank you for joining us, everyone. Nice to see you all. My name is Naomi Collett. I am the head of product here at Health Engine, and I'll be hosting this webinar today. I won't be doing most of the talking, though. I've got a very great panel with me to help educate everyone on all things assignment of benefit. So I'll just introduce my colleagues who will be helping me today. So starting off with Dr. Ramya Raman. She's a specialist general practitioner, medical educator, and health policy leader. She's now based in Perth and is the director of the Garden Family Medical Clinic in Piara Waters, where she continues in clinical practice. We are super lucky to have Ramya with us today, given her schedule and the demands on her time. And she's written articles about the recent assignment of benefit changes and is very well versed in everything. So she'll be our guide through this process. Also joining us is Dr. Amandeep Hansra. She's the Health Engine's medical director, a practicing GP, a leading voice in digital health, and having served as the chief medical officer for Telstra Health, head of the clinical innovation at NIB, and advisor to the Australian Digital Health Agency for over 6 years. And she's also a fellow of both the RACGP and the Australian Institute of Digital Health. So fair to say she's basically a rock star in the medical industry. And also joining us is Nicole Schneider. She is our senior product manager here at Health Engine. She looks after all things GP technology software. She's been staying abreast all of the changes with assignment of benefit as they've evolved and changed, and is the brains behind the solutions that we've built to help medical practices manage themselves through these changes. So just moving on to the agenda of how this will work, starting off with just a little bit of housekeeping. So if you do need to drop off at any time during the webinar, there will be it is being recorded now, and we'll send through a link to the recorded version tomorrow. So you will receive that via email. So if you need to leave for any reason, you don't need to worry. We will be able to send around a version of that. So what we're going to go through today is discuss all the different the changes that have been made with the assignment of benefit, talk about how we can help and the product that we've developed to be able to help your practices stay compliant. And we'll finish off with a final word from Dr. Amandeep. We'll also then do a Q&A, so feel free to ask questions in the question box within Zoom, and any questions that you have we'll answer towards the end. We might also do some after Dr. Ramya's section as well. So if we don't get around to all questions, we will be able to follow up with an email after this. So if you ask a question and it doesn't get answered, we should still be able to answer that. So moving on to what is happening, and I'll hand over to Dr. Ramya Raman to take us through all these changes.
Thank you so much for having me on today. This is a really important topic to be discussing, and more importantly, I'm here discussing as a GP and as a practice owner. Hand on heart, when I actually heard about this, I was thinking, goodness me, how are we going to manage this period of time with the transition coming on the 1st of July? Several conversations with the practice team, several conversations to really, understand and appreciate what it means for the workflow of the patient. So the good news now is what has been heard from GPs as well as their practices, and a shout out to the college for the advocacy in this space, is that there is a 12-month transition period, and it provides us with an opportunity to, one, understand what it means, to appropriately have the opportunity to discuss the options with your practice team, as well as have the confidence in building that workflow whilst we understand things a little bit more. So just jumping into the nitty-gritty of it. So what are the assignment of benefit changes? So as we know, Medicare is modernising the assignment of benefits for bulk billed services. So just to be really clear in terms of what we mean by bulk billed, there is a patient Medicare rebate, and the patient Medicare rebate belongs to the patient. Often when a consultation, not often, all the time, when a consultation is bulk billed, the patient then reassigns that amount back to the clinician. So this process here, known as the assignment of benefits, is primarily for bulk billed services, and the focus is to ensure that there is clear patient consent, a written or a digital agreement, and more importantly, also noting that the records can be retrieved for an audit if required. It's also important to understand what isn't changing and what is changing. So let's go through what isn't changing. So what isn't changing is bulk billing still requires the patient consent. The Medicare claiming process in itself is not the main change. And patients are still assigning their Medicare benefit or the rebate to the provider, which is what I highlighted earlier on. Practices still need to have a fallback if the consent is not captured appropriately. So the next question on hand is what is changing? So digital consent is now supported beyond telehealth. Practices can use their own paper or digital format to enable this. And it's important to note that consent must include the required data set. The records need to be stored, and new terms may then appear in the billing workflow. So it's about understanding what it means for your patients, what it means for the demographics of your patients, and also understanding the workflow that are associated with it. Now, this particular part, when I heard about it first, it's actually quite confusing. So key terms is a real good opportunity to go through this with your practice team. So the key terms to understand is pre-service assignment, so whether the consent is going to happen before the appointment. Then there is a post-service assignment, so consent that's happening after the service, but prior to the claim being lodged. There is an assigner, which is the patient or the person signing on behalf of the patient. And then there is the basic description and also the pending and the accepted assignment of benefit, which implies the consent status and the PMS workflow. The important thing with this is not to get too tied down on these terms. These are all readily available. That's why we're walking through it. And your vendors and your providers will be able to sort of walk through and help understand this a little bit better as well. So what do we mean by a pre-service assignment? So this is captured prior to the appointment, and it's often quite suited well when we know who the provider is, the service category that's being applied, and the services are unlikely to change. Now, there's a little flow diagram here that you can see with the patient is shown the assignment of benefit agreement. It then includes that basic service description. There's the patient or the assigner who signs that. The service is then delivered and the practice confirms the service. So again, it's just very handy to have the workflow, and now is probably the time to work through and understand what the workflow looks like for your patient. It's always going to be a little bit different. I found that with my patients and my patient cohort as well. And sometimes it's different to one of my colleagues in the practice who has a different patient cohort. And of course, it's always different when we've got to think about patients who are in aged care, who are older, or who may need another member of the family actually providing this consent process as well. If we talk about the post-service assignment, so we're talking about what is captured after the service is delivered, but before the claim is lodged. So it's really important to have that distinguishing factor there. So captured after the service, but prior to the claim being lodged. So you can see here that this is the closest we have to the current sign-off after the consult workflow. The agreement must reflect what is actually happening, including the MBS item numbers. And again, the flow chart onto the right here gives you a really good idea about how to work through that and a good explanation for your practice staff to be able to refer back to it. And so there is clarity. So the clinicians, the nursing team, as well as the front desk team and the reception and the management team have a good understanding about how things would be progressing through. So what do we mean by the required data set? So when we talk about the required data set, the assignment of benefit needs to capture all of the requirements that are listed there. So I'm not going to list it. It gives you some really clear clarity on the things that need to be there. To be honest with you, most of this stuff are things that we hold in our medical records to have a better understanding of it. But I think the key here is letting the team know that this is what we need. This is the things we are preparing for, and also bringing the patient along on that journey. Often patients feel more empowered and feel, yep, we can deal with this if we are able to know exactly XYZ needs to be done in that period of time. Now, a quick note in relation to the enduring assignment of benefits. So enduring assignment of benefit is done when there is an intention for ongoing future services from a preferred clinic or a practice. Now, it's just really important to note we're waiting on the final details about the enduring assignment of benefit dataset. So just important to keep that in mind. There will be more information that's coming. And the key thing here would be the expected use of the cases include eligible cohorts, such as patients who are registered for Medicare and patients who are getting their services from an Aboriginal controlled healthcare unit or an AMS service as well. But again, just to reiterate, we're still waiting on some final detail. We're going to get to know more about it. So more to come on this very soon. So what should practices do now, and what are the next steps? And that's a really important thing to consider. Key thing, it's a good thing we've got this period of 12-month period of time. Need to decide what your workflow is. Understand the communication patterns within the practice. Think about what would be the most efficient workflow to communicate this within the management team as well as with the clinicians. It's also a really good touch point to understand who your patients are and the type of patient cohorts and demographics you're servicing. Because I often make a list and just go, these are the major groups, so that we can understand whether it's going to be the patient consenting or perhaps if it is the patient's family member who's consenting and how we progress through that. So as a summary point, decide which agreements and format work best for you and your patient demographic, and more importantly, your workflow. It's going to be different for everyone. Update the consent forms. Ensure the form template adheres to the required dataset, which has been discussed in the previous slides. Update your policies. It's actually really good practice from an accreditation point of view as well as ensuring that there is clear governance within the clinical practice. Communication. So communication with patients, communication within the team. So ensuring that the team, so the reception team, the management team, the administrative team, as well as the clinical and nursing team are really clear about what the next steps are. There's still information that we are waiting on, so that's important to communicate through, saying we're still seeking some clarity, waiting for XYZ to come through. And some of the assignment of benefits, we're hoping that there's going to be better clarity on how it actually works on the floor or on the ground, because as a grassroots GP, someone who's practicing, I know the pain points of what it means in changing workflow and also communicating with patients. Now, audit readiness is important from a practice point of view and in terms of policies. So this is a practice needs to be able to show that consent was captured before the claim, the required data set was included, the patient and the assigners have agreed, the record is retained for 2 years, and the record can be found anywhere that's needed. Now, that all seems quite overwhelming, because when I read that, oh gosh, goodness me, like the number of things we would need to go through. But the reality of this is work with your vendors that you have, seek out the assistance and the help, because the intent of this is to make sure that it's going to be applicable, practical, but also something that's not going to increase the administrative burden in general practice. So the key fact is we want to make it as simple and as achievable as possible. So there's more to come. I hope this is helpful, and I speak to you as a fellow GP, someone who is in clinical practice and trying to also understand what the workflow is going to look like for my team and my practice and my patients. So keep in touch with your vendors, reach out, ask the right questions, and hopefully that will enable the best outcome as well. And I'm pretty sure that in the next few months to come, there's going to be more discussion points in relation to what next, how do we do that, what's the most efficient way to achieve this as well. So on that note, I'm going to hand over to the rest of the team to talk you through the rest of the webinar.
Thank you for going through that, Dr. Raman. So just jumping into what is available. So if you go to the next slide, please. So Health Engine has a solution to support in this process. We know it's not something that's going to happen immediately, but it's something you'll want to transition to over the next 12 months. And we have an existing bulk build product. This is not necessarily a new product. It's something that has already existed with telehealth workflows. So it's something that we've already had in place, but we have evolved the product to work for the new assignment of benefit changes and including all the face-to-face appointments as well. So it is a post-service digital consent. So just to recap, what Dr. Raman was saying is that you have a pre-service ability or a post-service ability. And in the pre-service, you still need to have a backup of post-service, because if you do a pre-service assignment and something changes, you'll still need to do the post-assignment. So that's where we've started, and we can look to introducing pre-service once people get comfortable with the post-service assignment. So I'll hand over to Nicole, who's going to take you through how the product works in a little bit more detail. Just a quick note on the integrations that we have. This will work with best practice and medical director, but if you do have a PMS that you work with that isn't listed there, then reach out to your CSM. If you're a Health Engine customer, let us know, and we can look to address those if there's demand there for that. So thank you, Dr. Raman, and I'll hand over to you, Nicole, to take us through the changes. Thank you.
Thanks so much, Naomi. What I'll run everyone through is the practice journey, patient journey, and then just a few other things that can help you. So on the practice journey side, at the moment, you are able to enable bulk bill consent in Practice Admin, which is our SaaS platform, where you can do a whole bunch of other things, including recalls, appointment reminders, and lots of other features. So what you're able to do is you can select which appointment types that you actually want to enable for bulk bill consent. You don't necessarily bulk bill for all of them. So you have the option to either say you want to configure all, or you only want to select certain appointment types. You then should tell patients to expect an SMS and email at the end of their consult. This is just, again, to prepare them for everything. Then once the visit is completed, you'll go and generate your invoice. So in best practice, you'll ensure that the bill to is set to Medicare Direct Bill. In Praxoft, the invoice will go to bulk bill. When you then select to generate and store the invoice, or again in Praxoft, select voucher, what that will do is then allow us to go and generate the post-service agreement consent containing the required data set, including all your MBS items. You can then monitor the statuses for your bulk billing consents in the Practice Admin view, and you're also able to resend any requests that have not been approved. There is an automated 24-hour resend that occurs, but you can also manually go and resend it. Important thing to note on this flow is that we do send SMS and email at the same time. That's just to prevent people from thinking it's potentially a scam, and also just allows you to reach them across multiple channels. So what I'll now do is to step through the video that we have here. Okay, so as you can see, we have the bulk bill consent post-service assignment preferences. So you either have all your appointments or specific, and these are all the appointment types available in your PMS. You can then, on the overview page, see a whole bunch of stats related to your bulk bill consents. You can show stats for more than 7 days, so up to 30. You can monitor statuses. You can also download the PDF if you need to. The statuses do toggle between accepted, pending, and expired. You can resend your consent or even mark as complete if it has already been completed using a paper form, and that will then stop us from resending multiple consents. So it's all managed on a single screen. You can do your follow-ups from there, and also if you need to download the PDFs. However, we do write it back to your PMS for audit purposes. We also do store it for 2 years in case you need to retrieve it from us and not the PMS. Next slide, please. Now on to the patient journey. I'll talk through the patient journey and then we'll step through the video afterwards. So the patient will attend their appointment. Once you have finalized, as I mentioned, done your voucher and your invoice, the patient will then receive an SMS and an email. The SMS will be from our sender ID as part of the ACMA changes coming into effect on the 1st of July, which is HealthEng. So patients should always expect to receive an SMS from that sender ID. And then the email will have your practice name in front, and then it'll be a no reply at healthengine.com. The email also contains your practice logo and address and a few other identifiers. So it does just tie up the journey quite nicely. Once the patient clicks on the secure link in the SMS, they will then be asked to verify their identity. This is required for security reasons, of course, because we don't want to display sensitive information to people who should not have access. Sorry, losing my voice there. And then the patient can review all the information displayed to them, so the MBS items, the practitioner appointment date and time, to confirm it's all accurate. They then also need to state whether they are the assigner, or if not, then enter first name and last name if the assigner is not the patient. Once they select I agree, we then write the PDF back to the PMS, and they're also able to download the PDF. So if you hit play, you can then see what it looks like. Okay, this is doing a check to the PMS to ensure that we have the correct patient. You can see all the appointment details, the agreement type, which is post-episodic, all your MBS items, the benefit amount, your agreement, so is the patient the assigner or not? We do capture first name and last name if it's not the assigner. And then at the end, we also have the ability to actually print the agreement, which again, government legislation specifies you should be able to make it available to the patient. So that is the patient journey. Then the PMS outcomes, as mentioned for best practice, the PDF is written back to the PMS and attached to the patient file. If you are using the new best practice assignment of benefit solution, there is a new status available, which we update. So the status will change from pending to accepted. Also important, if you do generate the invoice and you are using their new solution, that you do have to select to not generate the assignment of benefit within BP, but to manage it externally. That's only for people who are opted into the new flow from best practice. And then for PracSoft, as we've done before with the telehealth solution as well, the PDF is attached to the patient file. Next slide. So it's important to come up with a plan for if you aren't able to get consent from a patient. The whole idea behind the changes is that patients should be able to know what they're consenting to and then basically give their approval to allow you to take their Medicare funds and assign it to the practitioner. So some fallback plans you could put in place. And again, you have 12 months to figure out what works for you and what you're comfortable with. You could resend the digital request, as I've spoken about. You can decide to capture paper consent if you are concerned. Again, very important to look at your patient demographic. If you have people who do struggle with digital technology, it's also not fair to expect that they need to now go and deal with a digital solution if you do have the option for paper. So look at what works for your patients, for your different appointment types, and pick something that works for you. You can also follow up with the patient, whichever way you choose to communicate with them, to ask them to complete their assignment. And then the final option that's always available, if a patient does not give consent, you are able to privately bill them and they can then take the invoice and claim it via Services Australia. So those are just a few examples of things you can put in place in case you are struggling to get consents. Next slide. And another big part of the assignment of benefit is to make sure that your patients are aware of what's coming. So communication to them is critical. It is quite a change. Not a lot of people are used to clicking on links and having to verify their identity. There's a lot of scams that happen out there, and people are reluctant to click on things. So showing them imagery of what an SMS would look like and a whole bunch of other things could help. The main goal here is to reduce any confusion that these text messages might cause, ensure that you have good completion rates, move people away from asking, is this a scam, and not wanting to click on anything. And the biggest concern is obviously needing more time from reception in order to follow up with patients. So if you can prevent that from happening by having a clear communication to your patients, then that is a win for everyone. What we do have available for you is a patient communication toolkit. We have in-practice posters that can explain to patients, again, what the SMS is going to look like, email, and what to expect. We have TV monitor images that you can put on TV screens in your waiting room. There are appointment pop-up notes that you can configure that displays during the booking flow. We can, again, just tell them to expect an SMS or an email post-appointment. You can update your booking confirmation wording, email reminder wording, and lastly, you can also use the Communicate product to send an SMS campaign before going live with the solution in order to tell patients what to expect. Again, communication to your patient is very important and is the only way that this is going to succeed. Thank you.
Thank you so much for that, Nicole. That was great. I've seen a few questions come through, but we'll just finish off with a word from Dr. Amandeep Hansra.
Thanks, guys. And again, apologies for earlier with some of the sound issues. Hopefully with the recording, we might be able to clear a bit of it up. So I guess in summary, I just want to remind everyone that, assignment of benefit has existed since Medicare was incepted. So it's not a new thing. It's just, us trying to, well, I guess the government trying to tighten up the regulations, particularly around verbal consent. And it all sort of came out of the National Audit Office, who's raising concerns about the compliance status of verbal consent processes. So really it's about trying to do the same thing, but making sure that it's done in a compliant way and that the digitisation process of it works. So obviously the college lobbied a lot around, the difficulty for some of the patient groups that are able to provide compliant consent under these sort of new rules, and that there was insufficient time to inform patients' practices and achieve that digital readiness by the 1st of July. So you do have the 12-month transition period, and I would suggest that you don't leave it till the last day of the transition period to suddenly get everything working. So you've got this period now to start testing it. So I would still, if your practice was preparing for it to happen on the 1st of July, then maybe still go ahead with that, because then you've got a chance to see when all of the, issues might pop up and how you can address those, or even starting with a bit of a pilot in certain groups. So just in terms of the enduring assignment of benefit, there's been a lot of questions about that in a few webinars that I've been. So still some details, obviously, that are coming out about that. But the registration with My Medicare is a really important one. So if you can get your patients registered with My Medicare, it's going to solve a lot of issues, because, obviously you want people to be signed up, but then they also get this enduring assignment of benefit sort of process locked in. There hasn't really been talk about what the compliance might be. So in terms of, audits and things, it won't be obviously in the transition period, but this will be after, I guess, in a year's time, just to be prepared that obviously these things will be looked at. So what I want to just, I guess, in summary is obviously you're hearing a lot about the workflows, the software, the legislation, but we actually have to think about the people that are going to have to work every day in this scenario, the GPs, the practice teams, but also your patients. So I know that every time we have Medicare changes, everyone gets really nervous about, is it going to mean more clicks? Is it going to be more paperwork? Is it going to be more compliance, less time with patients, more annoying things for everyone to do? I think the good news is this one is not actually trying to do that. This is really about trying to make sure that we've got good systems in place to capture something that we've always had to do from a compliance perspective. So the most successful practices that are going to get through this the best are not necessarily the ones with the fanciest technology, but they'll be the ones with the best workflows, and also that they've communicated it well. And we've talked a bit about the communication aspect, also just making sure that you're training your staff and that the process feels really seamless for patients. And that is probably going to be the one thing that is going to be a little bit tricky, is just trying to give your patients reassurance around, if they are getting more communication from you, whether it's the SMSs or emails, what does that mean and why do they have to do it? And a reminder of, what happens, I guess, if they don't do that, in terms of, the fact that that assignment is not compliant unless we've got their consent. So I just want to go on to the next slide. And I think that the takeaways, I guess, for everyone is that the requirements are changing in one way, but the assignment of benefit is not new. You're all doing it already. This is just about modernising the evidence that supports what you're already doing. And there are lots of technology solutions that can do it. I would also suggest that you don't try to do it through multiple technology platforms. So you're probably speaking to lots of the different parts of the vendor systems that support you. Just figure out where you're going to put this workflow in and try and keep it in one place, because that is where the tricky part comes about if you start to complicate it too much. So do think about this predominantly as a practice workflow rather than sort of a technology or software uplift. But having said that, if you've got technology and it's pushing updates, it's really important to take the updates, because some of them might be around, these supporting your workflow. So the good technology will help, and particularly having the most recent versions, but the success will really come from having clear documented processes for everyone in the practice as well as your patients. So reception staff, GPs, practice managers should all know, what's happening across the board. So my takeaway 3 is the patient communication. Don't underestimate that. For patients, they just see it as another thing I have to do, another, thing I have to sign or fill in. But we've just got to remind them that, they're getting bulk billed, and to be able to keep that service bulk billed, that you do require them to respond to those messages that you might push out. And so if they know that they'll receive that text or email to confirm their Medicare consent, then they will complete it. If they don't know that it's coming, they will most definitely ignore it or assume it's spam, particularly if it's, like a post consult message. And so just make sure you're having those simple conversations. And if, you don't want to kind of tie up all of your staff with having lots of conversations, but that's where some of the other media things come in handy, whether it's posters or videos or updates on your website. So I just want to, finish by saying, look, we've got a really valuable 12-month transition period. Don't see it as 12 months to keep doing what you're doing and wait till the end to change. I'd see it as an opportunity to test and learn, and you might just want to test and learn with one particular group first. So you might say, we're just going to do it in our telehealth workflows initially and see how that goes. So start small. Learn what works for your practice. If you've got issues, then go back and reiterate the process and see how you can improve it. But just make sure you take your whole team with you, and that you keep your patients across what's happening as well. And then you'll end up with a compliant process by default, and you'll also have probably a simpler, more sort of digitized system that will endure, past all of this. So I just say, don't be scared, but start early and use your full 12 months. And that's it from me. And I'll hand back to you, Naomi.
Thank you so much, Amandeep, and thank you for everyone who's asked a question. We'll jump into the Q&As now. One of the questions was around whether we'll get a copy of the slides, and we will be able to send that through. So we'll send out an email tomorrow with any common questions for people who missed that, as well as a copy of the webinar. So I'll just jump into a few questions. One says, are Health Engine going to offer an app for practices to sign the assignment on a tablet in person at the end of the consult? So Nicole, did you want to speak to that one?
Yes, so we are working on what we're at this stage calling our kiosk. which one of the applications that will run on this kiosk is check-ins, as well as the ability to do your Medicare Assignment of Benefit post-consult. So once you've, again, finished up your consult, the patient will be able to go to this kiosk. They'll be able to do their verification. Based on that verification, we'll be able to get all the MBS items linked to that invoice and, again, display the agreement as I showed earlier on the kiosk. They can do their consent there and then, with the ability to also then email the finalized PDF to them if they do want a copy. And once again, as mentioned earlier, we'll write back to the PMS to say that it's all been accepted and attach the PDF to the patient file. At the moment, we are, by the 1st of July, going to have the timing down to less than a minute for you to go from generating your invoice to the patient being able to complete that entire journey. So it'll be a smooth and seamless option for all practices out there.
Thanks, Nicole. And just a couple of follow-up questions related to that. Someone asked about cost. We don't intend to have any cost, although the cost of the hardware, obviously, if you're buying an iPad or something, will come to your business. But in terms of the software, there is no intent to charge for that. It'll be part of the current software subscription. There was another related question around can we do pre-assignment on the kiosk on arrival or only post? Nicole, did you want to speak to that one?
Yes, so as mentioned earlier, at the moment, we are very much focused on post-service assignment, making sure that that workflow is 100% before we move into the pre-assignment world. So it's definitely something that we're looking at for future. Just right now, it's very much post-service.
So this question is probably best for you, Amandeep. For GPs who do nursing home visits, would it be ideal for residents to be signed up for My Medicare?
100%. So I think that's the quickest way that you get that enduring assignment of benefits. So yeah, as many as you can of your regular patients. One of the messages from the college was don't do it for random patients that are not your patients. Obviously, there'll be another practice who'll be trying to sign them up, and we're still trying to work out the details that if somebody has assigned an enduring assignment of benefit to another practice because they're signed up by Medicare, but then someone else sees them separately, do they go and get a separate one? And so we're trying to work out some of those details. But I would say if it's an aged care facility, you're the main practice supporting them, then absolutely try and get the enduring assignment of benefit.
Thank you. There's another question here on how do we get the patient communication toolkit? I believe that can be accessed through your practice admin portal. So I'm not sure, do you know the exact way to navigate that, Nicole? Or maybe we'll put that in the instructions in the email that we send out. And a link.
Yes, we did send an email a few weeks ago, just stepping through the exact screens and where to access everything. But you're always more than welcome to reach out to your dedicated CSM. They can step you through it. Otherwise, it is available for you. So we'll share the slides, and then I'll also make sure that we add the email we sent out onto the help center so you can access it from there as well.
Thank you. Another question here. What happens if you're a mixed billing practice with appointment types as not all patients will be bulk billed? How will this be catered for by Health Engine? So obviously the consent needs to be managed for bulk billing only. You don't need to be collecting consent for someone that you privately bill. But Nicole, did you want to explain about it's a setting of appointment types, right?
It's very much got to do with the invoice that you generate. So if you don't select Medicare direct bill or bulk bill in your invoice, then we won't pick it up and we won't send the consent for them. Even if the appointment type is configured for bulk bill consent, we do ensure that only if it's got that Medicare direct bill or bulk bill selected that we actually generated. So in that case, you can just go and enable the appointment type and we'll only send it for those that are being bulk billed.
Thank you. Amandeep, one for you. Have you any idea if reception staff can take verbal consent? I think I know the answer to this.
Yes. So during the transition period, you can keep doing what you're doing before. So certainly you can, practice staff can obtain it, but you've got to obtain it before the Medicare claim is lodged, and then record it in line with whatever you've been doing. So you've got to make sure that you've got some record in the documented workflow. Obviously, over past the transition period, that's the verbal consent will not be compliant. And so this transition period gives you a chance to turn that verbal consent process that you've had in place into an actual digital or enduring assignment of benefits process.
Thank you. There's another question about what happens to patients with no mobile or email. So with that one, you do always have paper as a backup. So within best practice, for example, you set a default, and that default might say if you want Health Engine to manage it, managed externally. But you can always, when you're submitting a claim, when you're saving the invoice, you can get the patient, you can click print to PDF. And that will actually print out a paper copy. So you can do that. Obviously, a tablet is another good solution for people who don't necessarily have a phone or email. I don't know if you have anything to add to that, Nicole. You're kind of just nodding. That's good. There was a couple of questions related to what do you do if you bill privately because the patient refused to give the consent or they never got back to you. So someone said in regards to, if there's a patient, and they're drug seeking or something and they don't get a prescription that they want and they decline to sign, what do you do? This is a bit of a tricky one because billing them privately makes a lot of sense and you can still have the right to do that, but would you lose your bulk bill incentive? That's a question I don't actually know the answer to. Do you know, Amandeep,
you don't get the bulk bill incentive if you go private, if you bill the patient privately. So you either turn it into a private, billing consult, in which case you have to then chase the patient, obviously, for payment, or you write it off, which is not ideal, but those are the sort of really the two options. But you couldn't keep the bulk billing incentive if you didn't end up getting consent from them for a bulk bill consult.
Yeah, for a mixed billing clinic, it should be okay because you can privately bill that patient. You're still going to have to follow them up for funds, or we do have the ability to take pre-authorization for payment if that's something that you want to add to your practice. So that's a possibility as well. Someone was asking whether email is new to the flow. I think that is. It was only SMS previously with the telehealth bulk bill consent. Is that correct, Nicole?
So what we had previously is SMS was always the first port of call. And if the patient didn't have a mobile number associated to their patient record, we would then fall back to email. What we've done now is we've just doubled up. So we send the SMS and email at the same time. Again, just on the patient communication side for that, when they do come into the practice, it's important to just ensure that their details in their PMS is up to date. Check that their mobile number is still correct. If they don't have an email address associated, maybe look at updating that because it does solve a lot of these issues if we're actually able to reach them effectively.
Thanks, Nicole. There was another question on alpha tags or the sender ID registration. So to be clear, the way when you send an SMS works is that you either send from a number, and that's what happens often if you send a message where it has in it, reply yes, no to confirm, something like that. That is different from sending from a name. So if you ever receive a text message from the ATO or AusPost, you'll notice that actually comes from a word. You can't respond to those messages. So they're two very distinct types of messages. Health Engine send both. So we send messages that come from the word Health Engine, so which we have registered. So there's no need for practices to do that. So when patients receive the message, it'll say it's coming from Health Engine. Those ones can't be responded to. Where the messages can be responded to, so replying yes, as an example, those are sent from numbers and they're not covered through the sender ID registration. So there's no need to register for your own practice because we've registered the name Health Engine instead. Hopefully that all makes sense. See if there's any. How do we bill kids was one of the questions. Nicole, did you want to take that one?
I don't know. Bulk billing covers children, I think, already.
I think it's more around how do they give consent, right? So the parent or guardian in this instance, when they receive the form, there will be a field that says, is the person filling in this form the patient? And if you say no, it'll say, okay, well, who is doing it, and then that's when the parent would, in most instances, would put in the name. So
Yes, so that's why the patient verification SMS will come to the parent's mobile number, because usually that is associated to the child. The parent will receive the SMS, they'll do the patient verification entering the patient's details, so their child's details will be entered. And then, as mentioned, as part of the new required data set, you do have to say whether the assigner is the patient or not. In this instance, the patient is not the assigner. So they'll select no. And as part of, again, the data set that we have to capture, we then ask for first name and last name in order to also then just add that on the PDF. And when auditing time does come around, you can at least validate who actually did the assigning. Sorry, I thought you were asking about how children get bulk billed, and I'm not the expert in that field.
No, that's okay. We do have a question around how enduring assignment works. I think I'll call out that up until about Thursday last week, enduring assignment wasn't set to come into place until around April next year. They've brought that forward to July 1, but haven't necessarily given all the details. Amandeep, I don't know if there's anything you want to add around what we know, if anything, yet.
No, we don't. We're still waiting for more detail.
Yeah, because it's not something that needs to happen immediately. As soon as we get the detail, we'll work on what that might look like. But yeah, there's been a lot of changes just in the last few weeks. There is a question on how to document verbal consent. Amandeep, do you know?
Yeah. Look, I mean, you don't need a specific script, so there's not something that's, written as this is what you should be using, but you do need a reliable audit trail. So you need to be able to demonstrate that you've asked it at some point. So you need to say that you got consent, who got the consent, when they got the consent, and that it happened before the Medicare claim was lodged. So I would just find a way to incorporate it into your system. Some of the PMSs have actually got updates that have come out with fields that will actually allow you to put an assignment type or an assigner field in them. And I think best practice has got a specific verbal and an enduring assignment of benefit options in the upcoming releases. So you could probably do it in there, but I think whichever way you do it, you just got to show that you can keep track of it and that you can show it if you're audited. But ideally you would have been doing that already. So I think just making sure that, somebody comes and has a look, you do have those process in place.
Thank you. There's a question around whether there'll be extra cost to the practice. So none of the solutions that Health Engine are building will be coming at any extra cost. It'll be included in the GP Complete subscription, the technology subscription, if you have that. And there was another one on currently, do all my Medicare registered patients have enduring AOB? I don't believe that comes along free for the ride. Just because someone has registered with My Medicare doesn't mean, I think it'll be an additional step to also get to collect that enduring consent, but we still have more information to come on that. I don't know if you've
Yeah,
got
so I think what are we asking if or retrospectively My Medicare registered patients automatically have enduring AOB? I don't think it'll be like an automatic thing. I think you'll have to actively get it, but then once you've got it, you don't have to keep doing it.
Yeah. Great. So I think we might wrap there. We are at time. Thank you for everyone who asked questions. And again, apologies for the audio at the beginning. If we didn't get around to a question, we will take notes of all of them and make sure that they're all responded to when we send out an email tomorrow with the links, with the webinar, with the slides and the answers to all the questions. So thank you so much for joining us today. There's some QR codes there on screen. So if you need any help of where to go to, or if you're a new customer and you'd like to get in touch, what you can do. So thank you so much, and thank you to Nicole and Amandeep for joining us, and for Ramya, who had to pop off a little bit earlier. So thank you all so much for coming.
Thank you. Bye-bye.
Thanks, everyone.